Hello everybody and welcome to our module on microcytic anemias. Before we talk about the microcytic anemias, let's talk about some of the measurements that are commonly performed to assess the red cells. There are three standard measurements of the red cells that are performed on patients. The first is a red blood cell count. This is part of the complete blood count, or the CBC, along with the white cell count and the platelet count. We also measure the hemoglobin concentration in the plasma. This is reported as a concentration, usually in grams per deciliter. And then the third standard measurement is the hematocrit. This is the volume percent of red cells. To understand this, let's look at this picture on the screen. This is what serum looks like when you spin it in a centrifuge. The liquid elements like the plasma will be at the top of the tube, and the heavier things like red blood cells and white cells and platelets will be down at the bottom. After you spin the serum sample, what you do is then measure the percentage of the sample occupied by the red cells compared to the whole, and that is the hematocrit, or the volume percent of red cells. If you've never heard of the rule of threes before, you will learn it intimately on your clinical rotations. This is an easy way to remember the relationship between the red blood cell count, the hemoglobin, and the hematocrit. So the hemoglobin is usually 3 times the red blood cell count, and the hematocrit is usually 3 times the hemoglobin. So for example, I've shown some normal values on the screen here. A normal red blood cell count is about 5 million cells per microliter. A normal hemoglobin is 3 times that, or 15 grams per deciliter. And then a normal hematocrit is 3 times the hemoglobin, or 45%. This is just a rule of thumb, but it's especially handy for converting hemoglobin values into hematocrit values. Another standard set of measurements used to assess the red cells are called the red blood cell indices. These are measurements made by an automated blood counter, and they are measures of the mean characteristics of a red blood cell. So the test I talked about on the last slide are measures of the total amount of red cells or hemoglobin. In the case of red blood cell indices, what we're saying is, what does the average red blood cell look like? How big is it and how much hemoglobin does it have? And these tests are very important in the evaluation of anemias, as we will see. The first of the RBC indices is called the mean corpuscular volume, or MCV. This is the mean amount of volume contained inside a red cell. So it's not assessing the total volume of all the red cells. It's saying, what does the average red blood cell contain in terms of volume? And the normal range is 80 to 100 femtoliters. The second of the RBC indices is the mean corpuscular hemoglobin, or MCH. This is the amount in terms of mass of hemoglobin per red cell. It's usually reported in picograms per cell. And then the final measurement is the mean corpuscular hemoglobin concentration, or MCHC. This is a ratio of the amount of hemoglobin in the average cell to the amount of volume in the average cell. It's a concentration of hemoglobin in red cells, and it's usually reported in units of grams per deciliter. Of the three indices, the MCV is the most important because it can be used to classify anemias. When patients have a decreased red blood cell count or decreased hematocrit, they have an anemia, but there are many causes of anemias. The MCV can be used to narrow down the potential causes because it divides the anemias up into a short list of causes based on whether the anemia is microcytic, normocytic, or macrocytic. Microcytic anemias have an MCV that is less than 80, macrocytic have an MCV greater than 100, and normocytic anemias have a normal MCV of 80 to 100. In this module, we're going to focus on the causes of the microcytic anemias in detail. You'll note that iron deficiency and anemia of chronic disease are on the microcytic list as well as the normocytic list. As we will discuss in this module, these two causes of anemia can potentially cause a normocytic or a microcytic anemia. We'll talk much more about that later. Let's begin our discussion of the microcytic anemias by reviewing some general principles. Most of the microcytic anemias are caused by some process that leads to a low hemoglobin inside of red cells. When there's not enough hemoglobin available, red blood cell precursors undergo extra divisions. This leads to the production of smaller than normal red blood cells. Because there's a decreased hemoglobin content in the red cells in most of these anemias, the majority of microcytic anemias are also associated with a low mean corpuscular hemoglobin mass and a low mean corpuscular hemoglobin concentration. In addition, the low hemoglobin content leads to so-called hypochromic red blood cells on peripheral smear. If you look at this picture on the screen, this is a patient who has a microcytic anemia. You can see that there are large pale areas in the center of the red blood cells. These red cells are called hypochromic, and they occur when there is a decreased amount of hemoglobin inside the red cells. There are three main structural components of hemoglobin, and if any one of these components is deficient or absent, that can lead to underproduction of hemoglobin, which can then lead to a microcytic anemia. So first of all, hemoglobin contains globin chains. These are proteins, and there are 4 chains found in 2 pairs in hemoglobin. So if you have underproduction of any of the globin chains, this can lead to a microcytic anemia. The other important component of hemoglobin is heme. This is the structure of heme shown on the screen. It's got an iron molecule in the middle surrounded by a large structure called protoporphyrin. So if you are missing protoporphyrin or if you are deficient in iron, these things can also lead to underproduction of hemoglobin, which in turn leads to a microcytic anemia. So once you understand these three components of hemoglobin, it's very easy to understand the microcytic anemias. Some of them are caused by loss of iron, some are caused by loss of globin chains, these are called thalassemias, and some are caused by inability to produce heme molecules. This occurs in lead poisoning and sideroblastic anemias. The first microcytic anemia we'll discuss is iron deficiency anemia, and in order to understand this anemia, we have to review some details about how iron is absorbed and metabolized in the body. So first of all, you should know that iron is absorbed in two forms from our diet. The first form is called heme iron, the second form is called non-heme iron. So heme iron is iron that's in the center of a heme molecule, and this is found in meats. When we eat meat products, we are eating the flesh of other animals that synthesize heme. Therefore, we tend to consume iron that's in the middle of a heme molecule, and this type of iron is easily absorbed by the body. The other type of iron is non-heme iron. This is iron that is free. It's best absorbed in the Fe2+ state, and vitamin C assists in absorbing non-heme iron by converting any Fe3+ iron into Fe2+ iron, which can then be absorbed by duodenal epithelial cells. Once we consume iron in our diet, the uptake into the body is regulated by enterocytes, and this is the major way by which we regulate the amount of iron in our body. There's an iron transporter called ferroporotin, which is found on enterocytes. It's also found on other cells in the body, and it controls the amount of iron that is released from the duodenal epithelial cells into the body. Once the iron gets into our body, we really don't have a major mechanism to excrete it in large quantities. A small amount is lost in sweat and the sloughing of skin and GI cells. Women lose some iron when they menstruate, but other than these two minor mechanisms, basically whatever iron gets into our body will remain in our body, and this is why patients who require lots of blood transfusions can become iron overloaded because they have no way to get rid of all that iron coming into their body in the transfusions. Once iron gets inside the body, it is always found bound to some other protein, and there are two important iron-binding proteins that you need to know. The first one is called transferrin. This is the transport protein for iron. It transports iron in the blood, and the level of transferrin in the serum rises when iron stores are low, and this will be important in a minute when we talk about how to diagnose iron deficiency anemia. The second important iron-binding protein is called ferritin. This is the storage protein. This protein stores iron intracellularly, and you can find ferritin inside of macrophages in the liver and the bone. So now that we've reviewed iron absorption and metabolism, we can understand the four important clinical measurements of the body's iron status. There are four blood tests that are routinely performed to estimate a patient's iron status. The first one is the serum iron. This is the amount of iron in the plasma. The second measurement is called the total iron binding capacity, or TIBC. This is the amount of transferrin in the serum. You can just think of the TIBC as analogous to a transferrin level. The third test is called the serum ferritin level. This is the amount of ferritin or storage iron. And then the fourth test is called the percent saturation. This is an estimate of the amount of transferrin that is bound to iron. You calculate the percent saturation by taking the iron level and dividing it by the TIBC. This will give you a ratio of these two numbers. The reason this is done is because sometimes the iron level can be low normal, but the TIBC can be very high. We'll talk about this in a minute, but this is seen in iron deficiency anemia. And in these cases, the percent saturation can reveal the iron deficiency state, even though the iron level may be at the lower limits of normal. So there are basically two mechanisms by which a patient can become iron deficient. The first is lack of iron in the gut, and the second is loss of iron, usually as blood. And we'll talk about both of these in the next few slides. There are a couple of special clinical circumstances where inadequate GI uptake of iron is common, and the first one is among newborn babies. So newborn babies deplete their iron stores that they get from their mother by about 6 months of age, and this is the reason that pediatricians often recommend adding iron-containing foods to the diet of babies by about 6 years of age. Babies who are exclusively breastfed can sometimes develop iron deficiency because they don't get enough iron from the breast milk. Malabsorption is another potential cause of inadequate GI uptake of iron. Any disease process that affects the duodenum can impair iron absorption. That's because iron is absorbed in the duodenum. In addition, any GI process that impairs acid production can potentially lead to underabsorption of iron. This is because when you lose acid, more iron is found in the Fe3+ state, and recall, that is the state that cannot be absorbed by duodenal cells. So for example, patients who are status post gastrectomy for any reason can have underproduction of acid. In addition, addition, patients on prolonged proton pump inhibitor therapy can potentially develop an iron deficiency anemia, and the mechanism of that would be loss of acid production. And then finally, in rare circumstances, malnutrition and underconsumption of iron can lead to an iron deficiency anemia. The most common cause of iron deficiency, however, is loss of iron from bleeding. For example, women who have heavy menstrual periods can become iron deficient. Patients with peptic ulcers can bleed into their stomach and become iron deficient. And then finally, colon cancer is a very important and dangerous cause of iron deficiency. Sometimes the colon cancer is asymptomatic and the initial presentation is an iron deficiency anemia. This leads me to one of the most important points in this module, both for the boards and for real life, and that is that any adult or postmenopausal female with iron deficiency must have a workup for colon cancer. This is a classic board question and also comes up in real life. Patients who present with unexplained iron deficiency anemia need to have a workup for a potential occult malignancy that is causing them to lose blood. Another important potential cause of iron deficiency is pregnancy. Women who are pregnant have what's known as a negative iron balance, meaning that they are losing more iron than they are taking in. This is because there's expansion of the mother's hemoglobin mass, which is a normal part of pregnancy. In addition, there's an increased demand for iron because the baby is trying to synthesize its own red cells. And for this reason, most prenatal vitamins contain iron. They also contain folate because folate is very important to prevent neural tube defects, but they contain iron because women need more iron when they are pregnant. Let me pause and make a side point here about pregnancy and oral contraceptive pills. Both pregnancy and OCPs can increase the plasma transferrin level. This means that the transferrin saturation may be low among women who are pregnant or women taking OCPs. Remember that the percent saturation is equal to the iron level divided by the TIBC, and the TIBC is a marker of the transferrin level. So when the transferrin or the TIBC goes up, that will make the percent saturation low. This can be important among women who are pregnant. If they have a low normal iron level, you may be wondering whether they have an early iron deficiency syndrome. The percent saturation will be low under normal circumstances in pregnancy, and it makes this blood test not very helpful. This is the reason that a low ferritin level is often used to diagnose iron deficiency among women who are pregnant or on OCPs. That's because of this effect on the transferrin level. And then finally, there are some rare causes of iron deficiency that you should be aware of, especially for your boards. The first cause is hookworms. I talk about these in more detail in the module on helminths in the ID section. Hookworms can live in the gastrointestinal tract and they can consume blood. They produce anticoagulants and they're able to basically suck blood out of the intestines. This is basically a variation on other forms of blood loss anemia, and the two hookworms that can cause iron deficiency are Ankylostoma duodenale and Necator americanus. Another rare cause of iron deficiency anemia is the Plummer-Vinson syndrome. This is a rare condition that has a poorly understood cause, but it results in a classic triad of iron deficiency anemia, a beefy red tongue, and the presence of esophageal webs. Esophageal webs are the very unusual feature of this disorder. I talk about it in the GI modules on the esophagus. In terms of your boards, this would likely be presented as a patient with an esophageal web, and they might ask you what else you should be worried about, and you should be aware that esophageal webs can be associated with iron deficiency anemia as part of the Plummer-Vinson syndrome. Now that we understand the potential causes of iron deficiency, let's talk about the steps that occur inside the body when there's a decreased availability of iron. So if a patient has increased iron loss, for example from bleeding, or decreased iron intake, for example from a GI process, this will lead to a situation where the rate of loss of iron is greater than the rate of intake, and this will lead to iron deficiency. The first thing the body will do is begin to deplete the storage form of iron, and this will lead to a lowering of the ferritin level on plasma blood testing. The body will also increase the amount of transferrin, which is represented by the TIBC on blood testing, and this is the body's response to low iron stores. The body is seeking more iron, and it's increasing its production of the iron transfer protein. Now eventually the ferritin or storage iron will be depleted and the serum iron level will begin to fall. This will result in a low percent saturation because when the iron level is low, the percent saturation is low. In addition, when the transferrin level gets high, that will raise the TIBC, so this also contributes to the decreased percent saturation. So over here on the left side of the screen, I've summarized the key findings on serum blood testing in iron deficiency. There's a low serum iron, a low ferritin, a high transferrin, and a decreased percent saturation. The anemia that occurs in iron deficiency is a microcytic hypochromic anemia. There are fewer red blood cells produced, therefore there is an anemia, and the cells are smaller. Remember, any process that impairs hemoglobin production can result in a microcytic anemia, and you need iron to form normal levels of hemoglobin. The anemia is hypochromic because there's less hemoglobin per red blood cell. This leads to hyperchromic cells on peripheral blood smear. And an easy way to remember the findings when you perform red blood cell indices is that they are all low. So there's a decreased cell size, so decreased MC MCV, there's less hemoglobin, so there's a decreased MCH, and there's also a decreased MCHC. Importantly, you should know that initially an iron deficiency anemia may be normocytic. The marrow may make fewer red blood cells but maintain the hemoglobin level and therefore maintain the size of the red blood cells. So just because the patient has a normocytic anemia, it doesn't exclude the possibility that they may be iron deficient. And in clinical practice, measurement of iron levels are something that's routinely done in any patient who is anemic, since the anemia may be microcytic or normocytic. Another characteristic finding among patients with iron deficiency is an increase in the RDW. RDW is the red cell distribution width. To understand this blood test, let's look at the bottom left side of the screen. I've plotted the red blood cell size versus the number of cells for a normal patient. You can see that the distribution of red cell sizes is relatively narrow. That's what you see in normal patients. In iron deficiency, the distribution width becomes much wider. That's because some cells are able to find enough iron to form normal amounts of hemoglobin. Those cells will be normal in size. Other cells have very deficient levels of iron and deficient levels of hemoglobin, and they will be very small. Thus, the distribution of sizes becomes much greater in patients who have iron deficiency anemia. You should note that this increase in the RDW can be seen in any nutritionally caused anemia. You can see it in iron deficiency and also in B12 and folate deficiency. In all of these disorders, some cells are able to find normal amounts of these nutrients to form normal cell sizes. Other cells are formed with deficient amounts of these nutrients, and thus they have very different sizes. This makes the distribution width much wider. The place where this is sometimes helpful clinically is in distinguishing iron deficiency anemia from thalassemia. Thalassemia can also cause a microcytic anemia. However, the red blood cell distribution width will be normal. That's because thalassemia is caused by deficient production of globin chains. It's a genetic defect, and therefore all red cells are subjected to the same problem. In iron deficiency, some cells are able to get enough iron, others are not, and therefore you see an increase in the RDW in iron deficiency anemia. Another blood test that may be abnormal in patients who are iron deficient is called an erythrocyte protoporphyrin level. Protoporphyrin is the chemical structure that surrounds iron and heme. I've shown it on the screen here. If you put an iron molecule in the middle of this, you would have a molecule of heme. So when there's not enough iron around, you will see elevated levels of protoporphyrin inside red blood cells, and you can detect that clinically. That's an increase in the erythrocyte protoporphyrin level, and it's seen in patients who are iron deficient. It's also seen in patients who have lead poisoning. Lead poisoning, as we'll talk about in a few slides, inhibits the addition of iron to protoporphyrin, so therefore you again cannot add iron to protoporphyrin, and the level of erythrocyte protoporphyrin may rise. This is rarely used clinically, but it can sometimes be used for screening. An increased level of erythrocyte protoporphyrin can suggest iron deficiency or lead poisoning. The treatment for iron deficiency anemia is very simple. It's iron supplementation. Usually this is given as a pill. Rarely IV iron can be used in patients who are severely iron deficient. The next anemia we're going to discuss is called the anemia of chronic disease. This is an anemia that occurs in association with inflammation. It's common among patients who have rheumatoid arthritis and also lymphoma. It's also seen in many other chronic conditions, and that's how it gets its name. The most important word to remember in association with this disorder is the word mild. This is usually a mild anemia. The hemoglobin usually remains above 10, and symptoms from anemia are very rare. If you read a question stem that describes a patient with a severe anemia that is highly symptomatic, it's extremely unlikely they are discussing this disorder. This is usually picked up incidentally on routine blood work. There are several mechanisms behind the anemia of chronic disease, but they are all triggered by cytokines. Cytokine levels rise in settings of inflammation, and this leads to a series of changes that produce the anemia of chronic disease. First of all, red blood cells in patients with this condition have a mild decrease in survival. They just don't live as long as normal red blood cells. Secondly, there is an inadequate EPO level and response to EPO seen among patients with anemia of chronic disease. They have lower EPO levels than expected for the degree of anemia. So for example, if a patient had a similar anemia due to iron deficiency, they would have a higher EPO level than what you see in anemia of chronic disease. The EPO level rises in both conditions, but it doesn't rise by as much in the anemia of chronic disease. In addition, there is less increase in the red blood cell production generated by EPO among patients who have anemia of chronic disease. And then the final mechanism, which is one of the most important, especially for step 1, is to be aware that there is a lack of availability of iron among patients with this condition. Iron gets trapped in the storage form inside the body, and the key mediator of this process is a molecule called hepcidin. So let's talk about hepcidin now. So hepcidin is an acute phase protein. It's produced in the liver and it has antibacterial properties. That's believed to be the reason that its level goes up in settings of inflammation. But the reason it can contribute to anemia is that it affects iron metabolism. It inhibits iron transport by binding to ferroportin. Ferroportin is the transport molecule we talked about before in enterocytes that lets iron get out of duodenal cells. It's also found in macrophages and it lets iron get out of macrophages. So when ferroportin gets inhibited by hepcidin, iron gets trapped in the storage form inside of macrophages. And for that reason, you see a rise in the ferritin level. This is a very important finding in anemia of chronic disease. This is the opposite of the finding you see in iron deficiency anemia. Just like iron deficiency anemia, this anemia can be normocytic or microcytic. Now, this anemia is most commonly normocytic normochromic. However, in about 25% of cases, it is a microcytic hypochromic anemia. The reason it can become microcytic is because the low iron availability can lead to underproduction of hemoglobin and small red cells, just like we talked about before with iron deficiency. Importantly, however, the MCV is usually only mildly decreased when the cells are microcytic in this disease. Remember, mild is the key word for anemia of chronic disease. So a normal MCV is 80 to 100, and the MCV is usually above 70 in this disorder. If you see a case described where the MCV is very low, they are probably not talking about anemia of chronic disease. And it's important to distinguish anemia of chronic disease from iron deficiency because this disorder does not respond to iron. The first line therapy is to treat the underlying disease and limit the amount of inflammation. That will make the anemia better. Let's talk about the diagnosis of anemia of chronic disease. Specifically, let's talk about the iron studies among patients with this condition. The serum iron level will be low. This is thought to be a protective effect of inflammation because bacteria may use iron for growth and metabolism. The ferritin is usually increased. As I mentioned before, iron gets trapped in the storage form in this condition because of higher levels of hepcidin. Now, in actual clinical practice, interpretation of a high ferritin in the setting of inflammation is challenging. That's because ferritin is an acute phase reactant, so an increase in ferritin may not necessarily represent an increased amount of storage iron. It may simply represent the effect of inflammation. But for the purposes of step 1 and the mechanism of anemia of chronic disease, you should be aware that ferritin can increase because iron can be trapped in the storage form. The transferrin level, or the TIBC, is usually decreased. Transferrin rises when total body iron is low. In this condition, total body iron is high because iron is trapped in the storage form, so the transferrin and TIBC levels will fall. This means that the percent saturation is usually normal. Even though the serum iron is low, the TIBC has also decreased. It makes the ratio of iron to TIBC, which is the percent saturation, normal. So here's a slide comparing the iron studies among patients with iron deficiency and anemia of chronic disease. They both can have low iron levels, so that's not very helpful. However, the ferritin goes in opposite directions. It will be low in iron deficiency and increased in anemia of chronic disease. The TIBC, or transferrin, also goes in opposite directions. What this means is that the percent saturation will be very low in patients who have iron deficiency, and it's usually normal in patients who have anemia of chronic disease. And then just for completeness sake, I'll add in hemochromatosis, which is a condition of iron overload. In that condition, the iron level is high. You also see high ferritin in hemochromatosis because there's too much iron in the body. The TIBC level is low in hemochromatosis. Remember, the TIBC level is elevated only when body storage iron is low. This means that you're only going to see it elevated in iron deficiency. And then the percent saturation gets very high in patients with iron overload or hemochromatosis. That is because the iron level is high and the TIBC level is low. They are going in opposite directions, so the ratio of those two will be very increased. Our next cause of a microcytic anemia is lead poisoning. Lead is toxic to red blood cells. There are a couple of ways patients can be exposed to lead. Among adults, it's usually from inhalation if they do certain types of industrial work. Battery factory workers are a classic group to be exposed to lead in their daily work. Children, on the other hand, are often exposed to lead if they eat lead paint, especially if they live in an old house. Many old houses were painted with lead paint, and when the paint flakes off the walls, the children can eat it, and thus they can develop lead poisoning. The reason lead is toxic to red blood cells is because it blocks heme synthesis by inhibiting two enzymes in the red blood cells. The first enzyme is called delta aminolevulonic acid dehydratase, or D-ALA dehydratase. The second one is ferrochelatase. We'll talk about what both of these do on the next slide. By inhibiting heme synthesis, this leads to decreased production of hemoglobin, and remember, anytime red cells cannot make enough hemoglobin, that leads to a microcytic hypochromic anemia. All molecules of heme, as shown on the bottom right side of the screen here, are derived from molecules of succinyl-CoA and glycine. The enzyme D-ALA synthase combines succinyl-CoA and glycine into molecules molecules of D-ALA. Then the enzyme D-ALA dehydratase converts D-ALA into porphyrobilinogen. There's then a series of steps which leads to the synthesis of protoporphyrin. Iron is then added to the center of the protoporphyrin ring via the enzyme ferrochelatase, and this leads to the final molecule of heme. The rate-limiting step is the enzyme ALA synthase, the enzyme that starts the whole process off. When there are low levels of heme, the activity of ALA synthase is increased, and this increases the production of heme. When patients have lead poisoning, they have inhibition of D-ALA dehydratase, as we talked about in the last slide, and also ferrochelatase. This will lead to very low levels of heme. This will stimulate D-ALA synthetase, and this will lead to high levels of D-ALA, and that's a characteristic finding of lead poisoning, is a buildup of D-ALA and high levels of D-ALA. In addition, some of that D-ALA will be converted to porphyrobilinogen. Some D-ALA dehydratase will still be active. It's not 100% inhibited by lead. So whatever D-ALA can get converted into porphyrobilinogen will then go through a series of steps to become protoporphyrin, but it can't go any further because ferrochelatase is also inhibited. This means that the level of protoporphyrin will also rise among patients who have lead poisoning. So the two characteristic findings are high levels of D-ALA and protoporphyrin via inhibition of the two enzymes in the heme synthesis pathway inside of red cells. Usually the condition is diagnosed by finding a low plasma lead level. However, for step 1 of your boards, they like you to know which intermediates in the heme synthesis pathway build up. So you should know that among patients with lead poisoning, you can also see a high level of D-ALA and also a high level of erythrocyte protoporphyrin. And we talked about this blood test before. It can also be used in screening for iron deficiency. There is a characteristic finding on the peripheral blood smear among patients with lead poisoning that is called basophilic stippling. Basophilic stippling is the presence of blue granules in the cytoplasm of some red blood cells. This is an example of basophilic stippling in this peripheral blood smear at the bottom right side of the screen. The reason for this finding has nothing to do with the inhibition of heme synthesis by lead. It has to do with the inhibition of another enzyme by lead called pyrimidine 5' nucleotidase. This enzyme normally digests pyrimidines in ribosomes and RNA inside of red cells, so when this enzyme is inhibited, there will be an accumulation of pyrimidines and RNA inside of red blood cells, and that leads to the presence of basophilic stippling. You can also see this in other disorders like thalassemias and some other anemias as well. The symptoms of lead poisoning are diffuse and can involve many different organ systems. Patients with lead poisoning classically have abdominal pain. This is called lead colic. They also often have constipation and headache, and these are relatively nonspecific symptoms, and this is why a diagnosis of lead poisoning is often missed. Some more specific features that can make you think of lead poisoning, especially in a board question, include lead lines. These are blue lines at the pigment between the gums and the teeth. They're caused by a reaction of lead with dental plaque. If you see a description of something sounding like this in a patient with belly pain, one of the first things you should think of is lead poisoning. Other symptoms include nephropathy. Patients with lead poisoning can have damage to the proximal tubules. This can produce a Fanconi-type syndrome where glucose and amino acids and phosphate are all wasted and found in the urine. Patients with lead poisoning can also develop neuropathy. A classic finding is drop of the foot or the wrist. Patients who have foot drop or wrist drop and also belly pain and lead lines, all this should paint a picture of lead poisoning for you that you should become familiar with before you take your board exams. The symptoms are hard to recognize in adults, but they can be even harder to recognize among children. First of all, children can't always give a clear history, and in addition, children often have prominent neurological effects, so they can develop behavioral issues, developmental delay, or failure to reach their milestones, especially in language. None of these things may right away make you think of lead poisoning, and for this reason, many places in the United States mandate screening of children with a measurement of a lead level. This is usually done at 1 to 2 years of age to try and identify lead poisoning before it results in permanent damage. The mainstay of treatment is to remove the exposure to lead. However, in some cases, chelation therapy is used. These are substances that bind lead and lead to its elimination from the body. They all have long, confusing names that are hard to remember. One of the substances is called dimercaprol, another one is called calcium disodium EDTA, and a final one is called DMSA, which sometimes goes by the name of Succimer. Our final cause of microcytic anemia is a sideroblastic anemia. So first let's talk about some terminology. Sideroblasts are found in normal bone marrow. They are nucleated red blood cell precursors, and they contain granules with non-heme iron. This is a picture of a sideroblast shown on the screen here. These little blue granules have non-heme iron inside of them. So a sideroblastic anemia is usually a microcytic anemia where you see sideroblasts in the peripheral blood. They should not normally be found in the peripheral blood. They are normally found only in the bone marrow. Sideroblastic anemia occurs when there's a failure to make protoporphyrin inside of red cells and red blood cell precursors. When this happens, there's no protoporphyrin for iron to bind to form heme, therefore iron accumulates in the mitochondria, and that leads to the formation of sideroblasts. Shown on the screen are some of the steps in formation of heme, and recall that the final step is combining protoporphyrin with iron to make heme. So if there's not enough protoporphyrin around, the iron level will rise and iron will accumulate inside of red cells, and that leads to the formation of sideroblasts. Usually sideroblastic anemias occur secondary to some toxin, so let's talk about some of the common toxins that lead to this problem. First of all is alcohol. Alcohol is a mitochondrial poison, and the initial steps and the final steps in heme synthesis both occur in the mitochondria, so if the mitochondria become poisoned from alcohol, that can lead to underproduction of protoporphyrin, and that can lead to a sideroblastic anemia. A second potential cause is a vitamin B6 deficiency. The reason this can cause a sideroblastic anemia is because the rate-limiting enzyme in heme synthesis, D-allosynthetase, requires vitamin B6 as a cofactor. So if you are deficient in vitamin B6, you will have deficient activity of this enzyme. This will lead to underproduction of protoporphyrin, and that can lead to a sideroblastic anemia. A place where this commonly occurs is among patients taking isoniazid for tuberculosis. It classically results in a B6 deficiency and therefore can lead to a sideroblastic anemia. And then finally, we talked before about how lead poisoning can lead to underproduction of protoporphyrin by inhibiting two enzymes in the pathway, so therefore lead poisoning is a potential cause of a sideroblastic anemia. Rarely, babies are born with a sideroblastic anemia due to an enzyme deficiency. The most common reason for this is a condition called X-linked sideroblastic anemia, where babies are deficient in allosynthetase, which, like we talked about before, is the rate-limiting enzyme for synthesis of heme. An important thing to know about this, especially for step 1 because it ties in with biochemistry, is that this condition often responds to treatment with vitamin B6. Vitamin B6 activates whatever allosynthetase is available, and this can increase the production of heme and sometimes result in improvement of the anemia. The lab findings among patients with sideroblastic anemias include a microcytic hyperchromic anemia. Remember what we've said several times in this module, that when you cannot make hemoglobin, you can develop a microcytic hyperchromic anemia, and if you can't make heme molecules in a sideroblastic anemia, you are not able to make hemoglobin. Importantly, the iron studies show iron overload. There will be a high serum iron, a high ferritin level, and a low TIBC and transferrin level. This is obviously very different from iron deficiency anemia and also different from anemia of chronic disease, where the serum iron would not be elevated. And then finally, the erythrocyte protoporphyrin level is usually low. This is because you cannot synthesize protoporphyrin, so therefore these levels are low. The one potential exception to this is if a patient develops sideroblastic anemia from lead poisoning, they can potentially have a high protoporphyrin level via the mechanism we described before. Finally, let me leave you with a summary slide on microcytic anemias. Anytime you're faced with a microcytic anemia case, you want to remember that there must be some problem in producing hemoglobin. You next want to think about which particular component of hemoglobin may be the source of the problem. If there's decreased availability of iron, then you may have an iron deficiency anemia or anemia of chronic disease. And remember that both of the iron-related microcytic anemias can also be normocytic in addition to microcytic. If there's decreased production of globin chains, then you have a thalassemia. If there's underproduction of alpha chains, it's an alpha thalassemia. If it's beta chains, then it's a beta thalassemia. And I talk about the thalassemias in a separate module. And then finally, if there's decreased production of heme, then you either have lead poisoning or sideroblastic anemia, as we just discussed. And that concludes our module on microcytic anemias.